Hello, my name is Emile Daoud. I'm Chief Medical Officer for S4 Medical. So a big problem for ablation of atrial fibrillation has been that when we use thermal ablation techniques, there's a risk of injury to the esophagus. And there's been varied devices out there, but for S4, we felt that there was a better way of moving or protecting the esophagus. And so our catheter, which recently got FDA approval, which is the first FDA-approved device for esophageal protection, is designed to deviate or move the esophagus. And the key point is there are other products that have tried to move the esophagus, but what we do is if you move the esophagus to the left, you have to bring along the right edge. And by using suction first, so we use a suction force, vacuum pulls in the esophagus, all edges of the esophagus get sucked in, and then use a mechanical deflection, and then you're moving the entire segment. So in that way, you don't have this issue of what's called the trailing edge not moving along with the entire deviated segment. So that's called an esolution. The concept is, again, to try to protect the esophagus during ablation of atrial fibrillation. So the energy, when you ablate along the posterior wall of the left atrium, the energy extends out and can injure the esophagus. And of course, there's fatal complications that can occur if a fistula develops. So by moving the esophagus relatively small distance, less than an inch, 20 millimeters, you can allow the operator to ablate on the back of the heart wall or near the pulmonary veins without risk of injury to the esophagus. The unique part of the esolution device is that it uses suction to grab all the walls and move the entire segment away. So we proposed to the FDA a randomized, placebo-controlled, multi-center, double-blinded trial. So patients that were indicated for an AFib ablation based on their electrophysiologist's opinion were the study population. The primary exclusion criteria were people that had some prior pre-existing esophageal disease, and the only other criteria is they had to be undergoing ablation with general anesthesia. So once the patient was in the room and they were under general anesthesia, they were randomized to either getting our device with a temperature probe, and our device is the esolution device to deviate the esophagus, and then the control group got conventional therapy, which was the temperature probe alone. The operator can do any ablation lesions that they wanted, and then we deviated the esophagus away from the energy, obviously in the deviation group, but not so in the temperature monitoring group. And then the next day, or typically within 48 hours, all patients underwent an endoscopy procedure, and the endpoint was to look for esophageal lesions related to ablation energy, or to also screen for any lesions in the esophagus that can be attributed to the device. And so the conclusions of the study, in fact, our Data Safety Monitoring Board recommended that we stop the study early after 120 patients were randomized because of far greater efficacy from the deviating device. It reduced the esophageal lesions by 85%, and there were no adverse events related to use of the device. Yeah, so obviously there's a lot of focus on pulse field ablation, which does seem to, at least right now using the current iterations, to be safe for the esophagus, but not sure in terms of the cost, efficacy, effectiveness, whether PFA will be that much superior than thermal ablation. So we believe that there's still going to be plenty of thermal ablation that will be done, and particularly if you want to protect the esophagus, we think this is a very inexpensive and easy way to use without any additional equipment. You don't need another piece of equipment in the lab to operate the device and provide protection for your patient.